The anterior lumbar interbody fusion, or ALIF procedure, can be divided into three distinct parts. The first portion of the procedure is the spine exposure, followed by the spine fusion. Finally, the wound is closed. The ALIF procedure is performed with the patient laying on their back in the operating room. Once asleep, under a general anesthetic, the affected disc spaces are localized using X-ray. This allows very precise localization of the disc space, along with positioning of the skin incision. Then, cleaning soap and sterile drapes are applied.
For low lumbar procedures, specifically the L5-S1 level, I typically use a low transverse or bikini type incision. However, when multiple levels are being accessed, a vertical incision is most commonly used. Once the skin incision is made, electrocautery is used to cut through the soft tissues, getting down to the fascia, that tough fibrous tissue that envelops the abdominal muscles. The fascia is then cut, which exposes the rectus abdominis muscle. As we discussed previously, I separate the muscles along its fibers, which is much less traumatic and allows for exposure of the underlying structures without need to reconstruct the muscle when the procedure is done. Once the muscle's been moved out of the way, the posterior rectus sheath and peritoneum are identified.
A retractor system is attached to the bed to ensure that all the critical structures that are moved remain protected and out of the way. The posterior rectus sheath is cut with cautery. Depending on the extent of the disc and spine exposure required, the posterior sheath may be cut for a longer distance. This fascial release allows for wide exposure of the retroperitoneal space, which the spine and blood vessels occupy. The peritoneum lines the abdominal cavity and protects the internal organs, such as the intestinal tract, during the procedure. The peritoneum is then separated from the abdominal wall muscles and moved to the opposite side of the abdomen.
After I've accessed the retroperitoneal space, I first identify the psoas muscle. Then I identify the ureter, which drains the kidney to the bladder and is often intimately associated with the major blood vessels of the pelvis. When I'm exposing multiple levels of the spine, I spend extra time freeing up the ureter from those vessels in order to minimize tension during retraction. The ureter is then moved along with the peritoneum and retracted. This allows me to keep it safe and protected throughout the procedure. The arteries, including the aorta and the iliac artery, are typically encountered next. Oftentimes, lymph nodes and the lymphatic drainage system are immediately adjacent to or surrounding those blood vessels. I use a special energy device to seal those lymphatics and reduce the likelihood of leakage of that fluid called lymph following the spine procedure. I then free up the arteries, followed by the veins. Now, the veins lie directly on the spine, and depending on many variables, including underlying spine disease, the blood vessels can be very adherent to the spine and require very tedious dissection. Additionally, there are branches from those vessels that I identify and tie off to allow for sufficient mobility and retraction on the veins.
At the L5-S1 disc space, the median sacral vessels are identified and ligated. Above this, there are segmental vessels that drain into the iliac vein and inferior vena cava, including the named iliolumbar branch, which lies on the L5 vertebral body and can be quite large. These branches are divided without any negative consequence.
With the vein completely freed up, I'm able to retract it significantly, which provides wide exposure to the disc space. The spine surgeon then performs the fusion part of the procedure. Your spine surgeon will provide a detailed description of the technique and specific instrumentation, including the products they may use.
Following the lumbar spine exposure, the spine fusion is then performed. The disc material is thoroughly removed and the vertebral bodies are prepared for the fusion using specialized instruments to scrape off the residual disc. A spacer or interbody graft, along with different products which stimulate and/or support bone growth, are then implanted. Different options exist for securing the spacer in place, including screw fixation or plating.
Once the fusion part of the procedure is completed, I re-inspect the area to make sure there's no bleeding and then allow all those critical structures to return to their normal location. I routinely place a tissue barrier between the blood vessels that I've just moved and the spine itself. This can protect those blood vessels from inflammation that occurs during bone formation and often contributes to scar formation in and around the blood vessels. The abdominal wall and soft tissues are then closed. I use absorbable sutures to connect the fascia back together. Finally, I close the soft tissue and skin in layers to optimize wound healing and minimize scarring. Antibacterial skin glue is then placed on the skin along with a dry dressing.